In the second lecture of this section, we're going to be hearing from Igor Grant. What else do I have to say? He was the executive vice chair of the department forever and just was an integral part of everything that we did. He became chair of the department and has done an awesome job in building upon the wonderful things that Lou Judd had accomplished before. He's also director of the HIV Neurobehavioral Research Program, which probably has more money in it than small universities in the Midwest. He's director of the Center for Medicinal Medicine, and he studies aging and Alzheimer's disease and home care and support of individuals who deliver care for Alzheimer's disease. But his focuses primarily have been, in recent years, on HIV and on drugs of abuse, with a special subspecialty on cannabis and its use in medical treatment of disorders. So his lecture is called Clearing the Smoke on Medicinal Marijuana. So Igor.
All right, thanks very much. Well, Sandy, what a hard act to follow this is. I mean, I don't have movies, I don't have 11,000 subjects, but the subject I have is very interesting. So I'm going to talk a little bit about the Center for Medicinal Cannabis Research, which is, I think, a unique thing that University of California, San Diego has. But before getting to that, just to remind people, marijuana, the cannabis, has many, many things in it, but the things that are of particular interest at the moment, especially medicinally, are THC and CBD. And as I'm a little bit of a fan of history, people who know me well know that, I think it's always important to acknowledge who contributed to the field, and the really granddaddy of the field of medicinal cannabis is Raphael Mechoulam, pictured here, an Israeli scientist. He's now, I think, in his early 90s, but still very active. He actually was one of our consultants a few years ago. And really, it was he and his colleagues who first characterized THC, or discovered that it was the chief psychoactive ingredient. They also characterized the structure of THC, and also cannabidiol, CBD, which is another abundant cannabinoid. Since there's nothing new under the sun, I thought that it would be of interest to remind us that Eli Lilly and Company, back in 1913, marketed cannabis americana, American-made, by the way, physiologically tested cannabis sativa, analgesic, hypnotic, antispasmodic, and powerful narcotic. Now, as it turns out, not all of these are false claims, as you shall see. With apologies to my neuroscientist colleagues, this is a cartoon that illustrates the distribution of one of the groups of receptors for cannabinoids in the brain. But before I get to that, let me talk for a moment about what's the buzz about marijuana anyway? Why did this come back out from the cold, if you will? Until the 1960s, actually, there was actually very little interest in marijuana or cannabis. It was kind of something that odd groups did occasionally. And then, of course, with flower power, the whole revolution beginning in the 60s and 70s, the cultural revolutions, cannabis was introduced into Western societies. And so our response as a government was, well, ban it. It's got to be bad. And that then led to sort of a lessening of any kind of research on possible medical aspects. There was a lot of research on harmful aspects, but not much on the medical aspects. However, the tide started to turn a bit in the 90s for several reasons. First, there are these persistent anecdotal reports of benefit, and particularly after the HIV/AIDS epidemic struck, a number of people would develop painful peripheral neuropathy as one complication of HIV/AIDS. And this is different than the pain, as you know, that you get from post-surgical or something like that, which is well treated with opioids or even non-steroidal anti-inflammatories. Neuropathic pain is this hypersensitivity, hyperalgesia, affects often feet, hands, and so forth, can be very, very uncomfortable. Besides HIV/AIDS, people with diabetes can get it, certain kinds of injuries, and it's not easy to treat. Best treatments are actually low doses of the old line antidepressants, tricyclics, that David Janowski is old enough to tell us about, and I can remember as well. Is that you, Dave, there? You've got a smile, Dave. That was a joke. The second thing that happened was, anecdotal evidence of benefit. Second is that the receptors that THC was acting on were discovered, and there are two known. There are probably others, CB1 and CB2. CB1 is very much distributed within the nervous system, but occurs elsewhere as well. CB2 is more an immune system receptor, but also occurs other places. And then, of course, since there are receptors, we know they weren't built to accommodate marijuana specifically. There were the endogenous compounds discovered, anandamide, 2-AG, and again, there may be others. So these are all elements that led to a resurgence of interest in this topic. Now, the Center for Medicinal Cannabis Research, again, something we can brag about as a department, thinking about our 50th anniversary. It was really established after the passage of Proposition 215, which is the so-called Compassionate Use Act. And California was the first in the nation to pass a medical marijuana law. Now there are medical marijuana laws in almost all the states of some kind or other, although their degree of permissiveness does vary. Anyway, the events that led to the establishment of CMCR after the Compassionate Use Act were that State Senator John Vasconcellos came to the university and through a long intricate series of events, ended up in Hillcrest in my office, said, well, I'll be transparent. I think medical marijuana is a good thing, but I don't think this is going anywhere unless we have a scientific basis for it. So what do you recommend? I said, well, set up a Center for Medicinal Cannabis Research at the University of California, San Diego, and we'll help you answer that question. He said, okay, how much? So Sandy, for those of you who have written large grants, this was an easier path to getting some funding. But it worked just as well. So they established the center, and our charge was to perform some early proof of principle studies. Now, one thing that you need to know is that research on medical marijuana is not like doing research on a new analgesic or psychotropic or anti-cancer drug or something like that. Being a Schedule I drug, cannabis is controlled by the Narcotic Convention. The only legal source of marijuana for medical studies is actually the federal government itself, which has a farm at the University of Mississippi. Tells you a little bit about Ole Miss, by the way. But anyway, we visited there. I think, Hamp, you went there, didn't you? I think I saw a picture of you among the plants. You'll have to report on that a little bit later. Anyway, the University of Mississippi then supplies the medical marijuana program that NIDA runs. And so the reason I show you this dizzying box of arrows and things is to show that in order to do the research, there are many regulatory hurdles. A lot of them are on the federal side, which are on the right-hand side of this graph, but there's also a state agency and so forth. So what we set up was we got some funding. We issued some RFAs to California investigators. We had a national panel review them. But once we thought that these studies were worth funding, all of these boxes and arrows had to come into play. And at the end of the day, it took about a year on average to get a study through the system. And the range was, there was one that got through in 6 months, but there were some that took 18 months, so it was that kind of range. So you can see why you need a center to do this. An individual investigator would have trouble negotiating all of these things. So our studies were all small-scale, short-term studies. However, the interesting thing is, if you look at the right-hand column, the result, they were all positive, and as I've said to others before, I really didn't expect that. I thought, at the end of the day, yeah, we'll do these studies, we'll spend the money, we'll have some fun, but we'll kind of be scratching our heads, is it working or not working? But in fact, every one of the studies showed a positive result in the short term. So that was quite interesting. And then if you look in terms of the neuropathic pain studies, how good is the marijuana anyway? NNT, as you know, is one measure of effectiveness of a drug. And compared to tricyclics, it's not quite as good, but it's pretty much as good as gabapentin, maybe outperforms lamotrigine, and certainly SSRIs. These are some other common drugs used in the treatment of neuropathic pain. So it ain't bad. Question, of course, remains how enduring is the effect? Do toxicities mount over time? We had very few toxicities. We didn't have to discontinue studies and so forth. By the way, these were, I don't know if you saw on the previous chart, these were modest amounts of THC administered, ranging from 2% to 7% in a marijuana cigarette. So, and as it turns out then, more recently, the National Academies did an exhaustive study of this topic, and they actually agreed with us. No, we agree with them, I guess, is a better way to put it, that there is substantial or conclusive evidence of cannabinoid efficacy in chronic pain spasticity. Control of nausea we knew about already because Marinol, which is synthetic THC, is already approved for that purpose, as well as for promoting weight gain in people with serious medical problems. I'm going to come back to this. And they concluded there was some evidence, moderate they called it, for improving sleep, although I think this is still a very lively and interesting question. I'm not sure I agree with their conclusion. That doesn't mean it doesn't work. I'm not sure the data are really as solid as they should be, and that's one area I'd like to very much see our center collaborate with our friends in pulmonology and everywhere to look at that. And then you can see down the list. Now, the one place this is out of date is they said not sufficient evidence for epilepsy, and as I'll show you in a moment, there is much better evidence for CBD in certain forms of epilepsy. So the question then comes up, let's say some of the cannabinoids, CBD, THC, et cetera, could be useful as medicine. How do you administer them? And it turns out that it isn't as simple a problem as you might think. You can see on the left-hand panel that if you're interested in THC concentration, the most efficient way to get it in there is to inhale it. You get a rapid spike and then a decline. It's sort of the auto titration ability is much better with inhaled. Oral is a little less reliable in the sense that some people just don't absorb it. Some people's bacteria like to chew it up, and so it never gets into your body. Then the liver, which is involved in the first-pass metabolism, likes to chunk out everything that it doesn't think you should have. So actually, the blood levels of THC and certain cannabinoids is much reduced, taken by mouth. And plus, the onset of action and its duration is very different. The onset may take an hour or two as opposed to minutes. And then people sometimes are thinking, well, I didn't have an effect, I'd better take some more. And then 4 hours later, they're really very impaired. Also, there's the question that sometimes more psychoactive substances are produced, like 11-hydroxy-THC, which is psychoactive, and that is produced by the liver, which you don't get if you take it by inhalation. As far as the inhalation methods, there's a dizzying number of things. This slide is antiquated. I'm sure we could show you 54 different devices for ingesting marijuana. But we were interested at one point, still are, about alternative inhalational systems that didn't involve burning and combustion. And so this gizmo, affectionately known as the volcano, allows you to heat the plant to a point of volatilizing the cannabinoids, but not burning them. And so it turns out that it works just as well. This is a study at UC Davis by Barth Wilsey, which shows that there is a significant, though not huge, positive effect of this vaporized THC. One thing that's very interesting in this study, and Mark Wallace also found the same thing in a different study, is very low concentrations of THC were actually beneficial. So if you look at the concentrations, 1.29%, 3.5, call it 2 and 4%. You know, any self-respecting pothead is not. They're not gonna even sniff at a 2% thing. They're going for 12%, 15%, and so forth. So we may have here the same phenomenon that we see actually in the old line tricyclics in the management of pain, that if you need to give Elavil or something, you may need to give 150, 200 milligrams to control depression, but only 75 to control pain. So there may be this difference, which may enhance safety. Let me spend just a few moments on CBD. I see the red light flashing here. First of all, it's important to know that CBD acts differently, or its physiologic effects are different than those of THC. I'm going to skip this and just come back here. The mechanisms of action probably do not involve CB receptors themselves. But there could be effects on the so-called vanilloid receptors, glycine receptor, which may be involved in the anticonvulsive actions, may inhibit fatty acid amide hydrolase, which actually degrades our internal cannabinoids, such as anandamide, makes it more available, may in fact enhance 5-HT1A receptors. Maybe that's the axial. So there are a number of actions, but they're not through CBD. So just coming back to this, one recent study, which got a lot of visibility, was by Oren Davinsky. And what he and his colleagues showed was that in children with these intractable but rare epilepsies of children, Lennox-Gastaut, and Dravet, the treatment with high doses of CBD did in fact reduce the number of episodes that these kids were experiencing. And that then led to the FDA recently approving the GW Pharmaceuticals product called Epidiolex for treatment of this disorder, and moved it to Schedule 5. By the way, CBD itself is in Schedule 1. That's a whole other story. There's kind of an interesting inconsistency, shall I say, in the scheduling. I think that Dr. Cadenhead showed this slide from the Lewicki study, and it basically shows that cannabidiol was just as effective as a traditional antipsychotic in the management of certain symptoms of schizophrenia, again, in the short term, but with the added benefit that there were improvements in negative symptoms that were not as prominent with the typical antipsychotics. That's panel C there. And also people did not experience some of the metabolic and extrapyramidal effects. So current CMCR-associated studies include these clinical trials that you see. They're funded by a wide variety of sources. The Wilsey-Marcotte study is a NIDA-funded study. An autism study is about to begin, funded by philanthropy. There's an essential tremor study, also a philanthropic study. And we're hoping to begin studies, hopefully this year sometime, on early psychosis and anorexia. In addition, Tom Marcotte is doing a very important study on cannabis-impaired driving. All right, thank you very much. I'm sorry, I'm 3.33 minutes over. I apologize. 4. I can't get any breaks here.